So first of all, to give you some background on why we're working in this area, how we came to this, we have been recently working on physical vital signs monitoring. We built a chest-mounted wireless monitor that more or less, in its next iteration, will monitor half a dozen of the most common vital signs, roughly what you'd get on an intensive care monitor. And it's a small, roughly, 2 square inches board. Designing that to be inexpensive and open up the possibility for inexpensive, cheap, personalized health monitoring. One thing, though, that we found as we talked to doctors about what this might be good for was that, in fact, it's probably an interesting and useful thing in the long term, but actually in the short term it's not a good mesh with the economics and practice of healthcare, certainly in the US, where there's an emphasis on very high accuracy diagnosis during a clinical visit, and less so perhaps on long-term health maintenance. Anyway, but we did get some interesting feedback from a lot of the doctors suggesting, well, maybe physical health may not be the most sanguine opportunity. Maybe the best opportunity is in mental health monitoring, where perhaps conversely from physical health, mental health is perhaps more naturally studied over time outside of the doctor's surgery, and that there could be a real opportunity. And we heard that even not from psychiatrists, from doctors in other practices. So can we really do something like this? What would you measure? And we started looking around and discovered some very interesting prior work. So this is just one work which was looking at a direct evaluation of patients who had clinical depression or patients who didn't from a control group. And they trained up a voice-based classifier and got a 95% accuracy just in that classification task on a group of patients. And that was using just, I think, somewhere between 15 and 30 minutes of voice. I can't remember exactly, per patient. And there was no patient history, so this was just someone off the street. In principle, you'd expect that sort of accuracy from classification. So that's very interesting as a baseline. And it suggests the possibility of having voice-based monitoring, which could be quite unobtrusive. Could be built into environmental microphones for at-risk populations, for instance, elders. And it also opens up the possibility of perhaps building some monitoring into cell phones. And I'll come back to that idea. So we do want to actually look at direct analysis along the lines of that prior work for conditions such as bipolar disorder and depression. We don't have approval for that just yet. We do have a proposal in progress, and we have a clinical partner at Berkeley from the psychology department who does deal with bipolar patients. But in the meantime, a closely related topic is analysis of emotions using voice features. And so it's interesting and useful to start developing the machinery to do emotion analysis, even if our goal eventually is mental health. But secondarily, the kind of analysis that's been done before seems to me very preliminary. So 95% accuracy already with very simple techniques that are a level of complexity below, let's say, speech recognition. And for instance, it does seem intuitively true that emotions themselves are useful features to use to higher level classification of mental health. So we might as well work on these, and I don't know if anyone's actually tried this, but instead of just taking features themselves and doing emotions or mental health, we think it's almost surely useful to do emotions from the low-level features and then look at more longitudinal fluctuations in those emotions to try to do mental health analysis. And of course, with emotions, we have it's much easier to get large data sets. In fact, there's existing data sets, which I'll show you in a second, which we can apply, and they're already classified and annotated. So our lab already works a lot with speech recognition technology, and that's another reason this area is attractive, because we have some familiarity with the tools. And there's an interesting observation that people have made about automated speech recognition, which is the accuracy is quite sensitive to emotional state. The systems are normally trained on quite uninflected speech, and even if they're very accurate on that kind of speech, as the speech becomes more emotional, the accuracy drops. Now that seems like a bad thing perhaps at first, but to us it's a very good thing, because it suggests that there are patterns in the voice that the speech recognizer is very much aware of that degrade its output. And currently none of that's factored into the recognition process. It does suggest if you did explicitly model those kind of changes and try to pull out the emotional state, and then in effect predictively push back in the effects, you should first of all improve recognition a lot. But secondly, the speech recognizer should be able to recognize a lot of the other features at higher level that go along with emotion. So anyway, it's given us a pretty clear trajectory to follow to try to develop better emotion recognition. So obviously dealing with mental health is an important problem, has direct impact, and it has impact on other health problems as well. Let's see. So we have the opportunity, especially if we look at voice, it has a number of nice properties. It's easy to collect the data with microphones. It's unobtrusive. It's a very non-invasive kind of a sensing. And it has the opportunity of perhaps being mediated by cell phones, which can put us, for instance, in touch with certain at-risk populations like teenagers. So I guess I'll have to go quickly through some of this. There are a variety of standard taxonomies of emotion. This is one of them. And the goal of emotion analysis is generally to classify a state into one of these archetypes. In fact, normally your measurements are quantitative, so actually you'll estimate somebody's state as being a position on this 2D chart. But, and I guess another thing to say is that the basic emotion states also seem to factor into these two basic axes that you can analyze separately. So there's related work in both areas. Previous work on emotions, especially from Ros Picard at the Media Lab. The more work is the one I mentioned about classifying depressed patients, and then there's several other ones. And the interesting high-level observation is that they're using roughly the same set of features, which does suggest it's worthwhile studying both together. So right now we're just doing emotions because of availability of data, and the data set that we're using is one of the standard data sets. It's not an ideal data set in the sense that the people are expressing genuine emotion, but they're doing that in the context of TV chat shows, where the emotions generally are hostility and anger and remorse and so on. So it's heavily skewed in that direction, not a lot of happy and neutral emotion generally, but still there's good dynamics in the data set, so it's at least worthwhile training, and it's already annotated. We actually would prefer to do our own markup using some other reality shows where there's perhaps a little less confrontation and more variety of emotions, such as, I guess, Bachelorette or something like that. But we're still getting to that point. So anyway, there is this data, there's a baseline. You pre-process the voice signal into various features. And as I said, these features are very low-level features. I'll show you what they are in a second. And generally, you'd prune down to a subset of the possible features. You use a classification system that's based on Gaussian mixtures. Probably not interesting for much of the audience, but that is the method used also in speech recognition. Roughly, key features are pitch, energy, glottal features, formants, sort of the, I guess, the resonances in the vocal tract. And let's see, I'll just jump to some of the results. So we're getting a 72% accuracy, which is more or less state-of-the-art for emotions. So, you know, to get calibrated when you're trying to classify emotions, because you have perhaps 8 outcomes, you expect much lower accuracy than, say, with depression. Assuming the algorithm is in a certain sense equally accurate, you'll get much lower accuracy just because it has to guess 1 of 8 instead of 1 of 2. But all we've done so far is basically reproduce the state-of-the-art to make sure we have all the bells and whistles and to get familiar with the features. Here's a list of the most likely features. This isn't the best ones necessarily, but it's a set that seems to be important. And you can see a lot of the glottal features are important, and that's consistent with Moore's result. Moore's result, actually, the 95% accuracy was just using one particular glottal feature to classify the depressed, undepressed patients. And I guess one thing I'll quickly say is that these are ratios of times here. All of these features are very low level. Basically, atomic measurement, or instantaneous measurements of some parameter of the speech signal. They're much below, say, recognition of a phoneme or a word, which takes time. And clinically, from what we can glean from psychiatry, is there are a lot of features that psychiatrists listen for that take a much longer time. And so these are not even being built into these models yet. So there seems to be a good opportunity. And here's a short list that we have come up with based on some testing and pruning of the features. So anyway, so it seems very promising. I got a couple of closing slides. One of the goals of the work, since we're building emotion recognition anyway, one of the difficulties of having sort of monitoring system like this is that people even at risk may not want to sort of adopt or use a system like this simply for the sake of mental health monitoring. And some people who are at risk may not know they have any sort of a condition that's starting to develop, wouldn't even think of using this. So what we're trying to do instead is develop basically some other incentives for people to use the basic emotion technology that will put them in the loop where we can study their mental state as well. And so, for instance, games are a natural application for this, assuming we can get a reasonable measurement of probable emotion state. We can, for instance, with characters like The Sims that have emotional degrees of freedom, more or less with very little interaction, just if you have the monitoring system in place during the day, if you get angry and frustrated or happy, your character is just running around in its virtual world acting out what you might do if you really had no self-control at all. And at the end of the day, you can see what happened, who got killed or who you ended up marrying or whatever. So this creates some sort of interesting incentives for people to use the monitoring system. We're just looking at really incentives for adoption right now, and hopefully in the long term we'll also get some actual clinical results. So, all right, so I'll just summarize the sort of 2 threads that we're currently working on, trying to get to here, but most of the work right now is on emotion recognition. Okay.
Thank you, John.